Hello, welcome to today's webinar, Mastering Care Gap Closure, Data-Driven Strategies. My name is Tiffany Guevara once again, and I am so excited to be your host today. Today, we're diving into a critical topic for healthcare organizations, which is closing care gaps to drive better patient outcomes and improve quality performance. Whether you're focused on HEDIS measures, risk adjustments, or operational efficiency, today's session will offer a lot of actionable insights that you can take back to your teams. We are joined today by two fantastic presenters, Kate McDonald, Senior Vice President of Strategy here at AristaMD, and Xanthe Bible, Operations Manager here at AristaMD. Together, they'll walk us through data-driven methodologies for identifying, prioritizing, and closing care gaps. Thank you for joining us today.
Thank you, Tiffany.
Thanks, Tiffany.
So before we go forward, let me just give you a little bit of overview of my background, and then I'll turn it over to you, Xanthe. I've been in and out of healthcare since I started my career. I'm not going to reveal how many years ago that was. Perhaps longer than Xanthe's been alive, but her and I have been primarily responsible for our care gap closure programs, particularly working with national level health plans, but also focused on what is our traditional target market, which is working with primary care practices. So even when we're doing programs on behalf of the health plans, our main engagement is at that practice level. So that's the experience that I bring to the table today. Xanthe, can you tell us a little bit about your background?
Thanks, Kate. Sure. I'm Xanthe Bible. I am the operations manager here at AristaMD, and I have been working in healthcare administration for about 10, 13 years, somewhere in that area. I began at a large education institution, hospital, where there was a lot of learning and growing through the Trauma Program Center, the fellowship program that I ran in nephrology in the past, and now I'm here as operations manager, and they're all kind of streamlined. So I'm working, as Kate said, I'm working with Kate on this project, and we're really passionate about the care gap closure, not only because of we want to do our best to help the providers, but also just improve patient outcomes any way that we can, and help solve for some of the administrative burden that so many providers are having these days. So we're happy to be here.
Great. We're going to jump right in. We're going to do this from the patient perspective, and I'm going to give a little bit of the framework. It's Xanthe and her team that do most of the outreach. So when we get into the specific details on, how to close those care gaps, I'm going to turn it over to Xanthe. So we're using Maria as our proxy patient, and we're going with what we consider the easiest gap to close because it is relatively simple from a documentation perspective. I would say the biggest challenge is often overcoming patient objectives. So Maria has a statin gap. She also has diabetes. So that gap is considered an open gap. She's 62 years old. She's type 2. She has been prescribed 3 times for the last 18 months. She filled once, discontinued after 2 weeks, citing muscle pain. And her PCP has tried education materials, follow-up calls, alternative dosing schedules. Nothing's worked to convince Maria. This is exactly the type of organization that we're outreaching to today and working with on a regular basis to solve these care gap closures. And many of you are probably aware that AristaMD started out as an eConsult and later a vConsult company with the merger with Sitka. That is one of the tools that we use to close care gaps, but it's not the only tool. AristaMD is now operating at full longitudinal care programs to support things like cardiology. And so when we think about some of the organizations we work with, here we're looking at a example or fictional organization, but the patient itself is pretty typical and follows what our common pattern is. And the patient population is about 75,000. They have 1,200 participating providers, lots of different touch points. And I will say that one thing that we see occurring is a drug will get prescribed in the hospital. The PCP may not know about that prescription. The patient may not be filling that prescription post a cardiac surgery or cardiac inpatient monitoring. And so one of the things that we often do is connect that data on the PCP's behalf and make sure that they're informed. So one open gap has haunted the dashboard for 18 months. That is the statin gap. PCPs are spending about 15 minutes per visit on statin counseling. It's a tremendous burden for that PCP, but quality scores are suffering, patient outcomes are suffering, and bonus dollars are at risk. So anytime that you're working within an MA population or any value-based payment model, this is an important gap to focus on. And what Xanthe's team and what we'll get into later has accomplished is providing assistance, really, so that PCP doesn't have to do as much of the administrative research work to get it all done for Maria.
Yeah. Kate, if I may, I would just like to make one comment on Maria's care there. Over 18 months. Now, we know the measurement year is only 12 months long. However, Miss Maria, because of her perhaps inability to either want to take it long-term or whatever that may be for her, we will continue to see her over 18 months regardless. So that would be a new gap throughout each measurement year, and she's going to pop up time and time again. So we definitely, everything you were saying, Kate, we like to put those cards together make those connections through the data for the PCP, and we'll let them know, hey, Miss Maria, she's on the open gap list again. Let's see what we can do here, and then I'll let you continue before I give too much away.
No, that's great. So here's the turning point and why organizations reach out to us. Before a routine follow-up, we've tried having the PCP do the direct outreach as an organization. Acme Health has educated their PCPs. The PCPs want to get these patients on a statin. They've reached out to us. We review the full case history. We provide the PCP with recommendations, some additional education directly for the patient, and citations, I think useful for both the patient if they want more details, and particularly useful for the PCP. So like every PCP, you're treating thousands of patients on your panel, and you have to keep up with every specialty. So when something changes in a specialty, it's almost impossible to keep up with every single possible new research study that comes up in that specialty. That's what our cardiologists are here to support. So on the right-hand side, you can see the AristaMD cardiologist has recommended a switch to a different statin and recommended the introduction of CoQ10 with a specific dosing strategy to address that muscle complaint for the patient. Also emphasize, and again, this is very abbreviated. Anybody that's ever seen an eConsult from us will see a lot more detail, but providing some of those patient benefits. It's a 25% reduction in risk of a heart attack. There's a decreased risk of stroke by approximately 20 to 25%. So that, showing to the patient, this has real value for you. This can keep you out of the hospital. This can help you maintain good health and be active and healthy throughout your retirement. Mm-hmm. So the next step is the patient, the PCP does another intervention with the patient. The PCP communicates the specialist recommendations, perhaps even shows the eConsult. It is part of the patient's chart, so it's perfectly acceptable to do that. Maria agrees to try the new approach. The outcome is the care gap's closed. What may not be seen is the follow-up that AristaMD is doing. Xanthe's team in particular is monitoring to make sure that gap remains closed, so that if that patient then doesn't fill the prescription again, that while the gap may be closed officially for the year and the star rating may not be impacted, your long-term cost of care as a Medicare Advantage participant or anybody participating in a value-based care knows that if Maria doesn't remain on the statin, her risk of heart attack or stroke goes up, and that could lead to an emergency room visit or an inpatient stay. And so we don't want to just close the gap. We understand that that has tremendous value, but we want to keep that gap closed as well. So we're going to be continually monitoring Maria to make sure that gap's closed. Now, we say that all of our current programs operate that way. However, if an organization comes to us and says, okay, once the gap's closed, I don't want you to monitor them anymore, we are willing to do that. It's just not our recommendation because we're really focused on patient care. And then it's also the multiplier effect. You know, the PCP is going to successfully replicate this approach with 12 other statin hesitant patients. And then your average time to gap closure, it drops from 6 months to 45 days. And one of the ways that we do this is with pre-appointment planning. And Xanthe's going to go into some of that detail here in a moment. Before that, I want to give you a little bit of the big picture. You know, there's system-wide implications. You know, so many Americans are not adherent with their medications. 59% of patients are not on a statin and report never being offered a statin. So one of the things that we can do is look at your patient data and provide some analytics that triggers, hey, here are the patients that actually need to be on a statin. Here are where your gaps are. Depending on the size of your practice, this can be a challenge. Depending on the quality of your data, it can also be a challenge because we realize that sometimes claims data is not as quickly reported as you might like. And then, you know, obviously we want to reduce those specialist referral wait times. So if a patient does need to be on a statin or if they're reluctant, you know, there are alternatives we can offer. So for example, in the prior example, we gave an eConsult. We can offer peer-to-peer, so video consultation if a PCP wants to go through a whole list of, you know, they have 10 patients with open statin gaps. Let's get them all discussed on one call rather than through 10 eConsults. If the patient has tremendous objections, we can also coordinate a telehealth visit to give that patient some additional reassurance, and we found that to be effective. I would say that is not the primary use case. It is the use case of last resort because we find that patients have the greatest trust relationship with their PCP and they want to take their PCP's advice. So if their PCP can reduce those concerns about muscle cramping or concerns about symptoms, you know, often they're in the best position to convince that patient to move forward with a statin. So the financial reality here is, you know, 75,000 members, high non-adherence rates, times $500 per half star rating. That's a huge opportunity. It's also a huge opportunity if you only have 10,000 members or 3,000 members. Each half star rating, particularly once you get, if you're between 3 and 4, has a huge impact. And not just on your, again, not just on what your reimbursement rate is for that star rating, but also on the total outcomes cost over time. So is there an ED visit that your value-based payment model is going to have to assume because that patient is not taking a statin and ends up in the ED with complaints of chest pain, for example? Only 8% of adults receive all the recommended preventative services. So this doesn't just apply to statins. This applies to many, many gaps that we see and really that are the focus of CMS today. We know from our claims analysis and historical data that you can realize 4 times the value with coordinated care gap programs, which is what we're going to talk about today. And we will share these slides because I did give you all those citations at the bottom, and I want to make sure that if you'd like to look at them, you can take a look and see some of those recommendations. So let's talk about the precision approach. What's new? Like we see SBC, BCE measures. There's multiple measures that have opened this year with CMS. One of them's targeting opioids. Another is targeting anticholinergics. For statins, we want to reach that 80% patient threshold. We want those to meet those gap closure deadlines. Mentioned it on an earlier slide. Depending on the size of your population, huge impact in dollars between a 3 and a 4-star rating. It's roughly $450 per member per year. If you can get above 4.5 stars, you're looking at closer to $600 per member per year in bonus payments. Additional revenue, from that higher rebate percentage, and then a compound impact, resulting in, a revenue of 13 to 18% per member. Mm-hmm. Finding your Marias. So this is a service that for our national health plans, we don't typically offer because they have access to that data and are relatively good at managing it based on the number of faxes and emails you probably receive from your health plans letting you know who has open gaps. But if you're looking in your practice across multiple health plans, some data oversight can be beneficial. So we want to look at one. The first thing we try to look at is there a PCP gap closure rate? This is where there might be a opportunity to educate the PCP, particularly when you're talking about a newly introduced gap. We've looked at some of the information that CMS puts out, that the health plans put out. You're looking at 60, 100, 200 pages of detailed care gap closure guidelines. This is not the fault of the PCP. They're dealing with 15-minute intervals, or even, in a value-based care program, maybe they have a half an hour with patients, or a very complex patient, they may even have longer than that. But at the same time, they want to be focused on the patient. They don't want to be in the weeds with the details of how do I close this gap, or who is an exclusion for this gap. Mm-hmm. And because it differs on every single metric, asking your PCPs to focus on every single metric may not be the best approach, which is why we look for those PCPs that have a red flag, let's say, because they may not realize that they have a cluster of patients that are not meeting one specific gap. So rather than educate them on every possible gap that's out in the world, let's educate them on the gap that is most impacting their patients and obviously your practice metrics. We also try to look at risk stratification. So when you're thinking about that star rating, you're not looking for the $450. If you're a PCP, you're really looking for the patient outcomes. If you're managing a practice and you're looking to drive revenue and financial stability for your organization, you don't only want to close the gap. You want to prevent long-term escalation of a patient's condition or symptoms. So that's why we try to look at the patient risk stratification. Do they have multiple gaps? Do they have multiple chronic conditions? If that's the case, we really want to prioritize those patients to get those appointments in first, to get not just the gap closed, but the full management of their condition, so we don't see an escalation and a diabetes patient having chest pains and going to the ED. I guess the final thing is time to closure tracking. It can take a long time to close a gap. And we're only in the second quarter, or we have 3 more days in the second quarter. Everybody tries to scramble in the fourth quarter to close all of their gaps. Realistically, it's not possible. You don't have enough appointments to close every single gap across multiple metrics at the end of the year. In addition, there's several gaps where you need to meet multiple guidelines in order to close that gap officially for the year. We see realistically, it takes about 60 days for the gap to close from the point of our first outreach to the patient appointment to getting the claims processed. This is going to give you kind of realistic expectations about what it takes to get it done. And then the 80-20 rule, we want to focus on the high impact gaps first, which is why we look at that patient risk stratification. I will say it's a service we're willing to provide, but if you know who your gaps are, and you know who the providers are for those gaps, we can certainly take that information and work with that as well. But our typical program focuses on quick wins versus complex cases. So where can we have the most impact very quickly? Patients that are at risk but need a prescription or are not known as a gap. And then for those complex cases, we know they take a little longer. So we want to start the work on those. And we often have to work across multiple providers to get that gap closed. Again, because you often have multiple conflicting prescriptions, we need to make sure that we're not going to create any unplanned drug interactions. And then we want to set a realistic target. We think an improvement of about 32% is achievable. And that's what we try to focus on, so that you have realistic expectations as you look through where your gaps are and where they could be in a quarter or in 6 months. That, I'm going to turn this over to you, Xanthe.
Thank you. Yeah, Kate, so exactly what you were saying, and building off that as well. We, the cardiologists, many of the providers that we speak to are just truly underwater with administrative burden. Like you were mentioning, there are multiple care gaps throughout the year. They're ever changing. There could be an exclusion for a gap one year, and then, it's no longer an exclusion the next year, or that exclusion changes and now you need a second documentation. There are so many ways that these things change, and it's our job to review those and ensure that we are discussing these with the providers as we establish those relationships. So we're able to see these patients with the SPC, for instance, the definition you can see here, it is for a young population and an old population, as well as male and female. That is a huge range of patients that you're looking at, specifically for a particular gap, and ensuring that each documentation is placed appropriately. It could be just as simple as not placing the code on the provider's visit note while they're in with the patient. It could be various things that are just so simple that we get to see. And as we develop those relationships with the clinics, we're able to discuss the patients on, at least the one high or moderate intensity, making sure that you are providing that education about, hey, if you use, let's say, where it says does not apply to CMS star ratings for Medicare members. So that means if a patient goes in and they use their GoodRx or they get a discount card, that will not show up in claims data. Therefore, it's an open gap. So that's a very simple conversation we have. Like Kate was saying, our quick wins, oftentimes we'll see like, oh no, this patient, we see that they are on this medication, but yet they're still on your list in the claims data. Let's see what happened here. Maybe it's just that claim was reversed, or a number of things. So we get to dig into that for the provider. Not each provider and their care teams and their coders, they typically there's not robust teams in most instances that can look into all of these minute details like we are able to do.
And in the case of the statin gap, they do accept that unstructured data, and GoodRx is surprisingly one of the main sources for our open gaps that we see. And so just having the patient bring in their prescription, capturing a photo of it, loading it into the EHR, attaching it as unstructured data, this might not be something that the PCP is completely familiar with how to do in their EHR. There's so many different EHRs. We can help make sure that unstructured data gets to the right place.
Mm-hmm. Yeah, thank you, Kate, definitely. And then we'll make sure that we give you that follow-up process. Hey, call this patient in for either a telehealth. Let's do, maybe perhaps if the provider has eConsult, do an eConsult. If there are various ways they can meet with that patient. If they're not on the statin, then we'd like to recommend various ways for them to do that as well in order for that prescription to be activated and or the gap closed as soon as possible. The other indicator we see here for like controlling high blood pressure, for instance, this is, again, very wide range of patient population that you're looking at. It's patients with type 1 and 2 diabetes. There are a number of things that can fall within this controlling high blood pressure gap. For instance, the medication adherence, which we like to just mention while we're discussing these gaps with our providers anyway. We just say, hey, just make sure that you're aware of this, that they'll need to be on it for the full measurement year and throughout the rest of the measurement year, or else this gap will open. And then here are some resources. And we love to point them back to the resources that we provide, that other health plans can provide, and give them that exact, this is where you should review this information, and give them a really controlled place to look.
And with blood pressure, I think one important takeaway is, unlike a statin, where with a Medicare population, they have one fill for the year and the gap gets closed. When it comes to controlling high blood pressure, the trick is not just to get the blood pressure in control, but to maintain control throughout the year, because it is the last blood pressure reading of the year that counts. Ideally, the last documented. And you want to make sure that that patient's blood pressure is controlled, because it isn't a one and done metric in terms of closing your gap.
Mm-hmm. Correct. Yeah. And you can call them back in, or I think there's some unstructured ways to do the blood pressure medication reading, blood pressure again, and have that documented as well. So there's really very many, there's a lot of ways to close and or see those exclusions on patients just like this.
Next slide.
Yes. Okay. Okay. So we are solving real problems. As you saw with Maria, as you heard us discussing, we believe that closing care gaps effectively is paramount for everyone involved. We're incredibly passionate about optimizing this process, operations. So very, very passionate about that. Our dedication to improving patient outcomes is fueled by a robust data-driven approach. We focus on operational excellence and delivering personalized and focused approach, which truly makes a difference. This translates into more efficient provider engagement and, most importantly, healthier lives for patients. One thing I always like to mention is that we don't want to just bother a provider if it's unnecessary. That's why it's so important to review the data thoroughly prior to those connections and really come in with an approach that is not just, hey, can we sit and chat about all of these and review them all together, but here are some things that we noticed, and have a very clear and determined approach. The coordination with the coding, like the exclusions or the pharmacy records, as Kate mentioned, and appropriate documentation in the patient chart. Those are all things we go over with the care teams as well when we're in communication with them. We have some of the best conversations and touch points with the care teams. They truly care about their patients as well, and they genuinely are trying to do the best that they can with what they have. And again, administrative burden. We all know this. We'll say it a million times, but it is a lot sometimes. And just having another person come in and say, here's what we noticed. Could you verify this? Let's walk through it, all before we reach the provider, and just ensure that this patient list is correct and that they should be talking, the cardiologist and the provider should be talking about these particular patients. We also form relationships, and we follow up with these organizations and clients and clinics that we all that we form or have those touch points with. And we genuinely enjoy talking with so many of them. And it becomes really personal for our team as well. And you can just hear or see in the data too, as those gaps start to close, they are then educated. They can come to us and ask for advice on the next measurement year, or they'll ask, hey, we have this tricky situation and this patient's not falling off. Can you maybe look through this with us and see what's happening here? And we're able to take a look, give some advice. And if it's more clinical, then we are happy to pass off and connect the cardiologist to the provider, either async, eConsult, something that just works around the provider schedule. We know that they're so busy and seeing so many patients, and we just want to make the burden a little lighter. So then we'll just monitor the patient. We'll track and update their records. Like Kate and I were saying earlier, we will follow a patient forever. We'll want to make sure that once their gap is closed, that we're not seeing them again that next measurement year and say, oh, why did Miss Maria miss her medication this year? Let's make sure she gets back on it. Is anything going on? We know that she was able to get her prescription filled, and that she has been great on keeping that medication filled every month. And then we can just do a simple check-in and with a provider that we've created the relationship with, or their care team, and say, hey, Miss Maria popped up again like this year, and we noticed that she had no problems last year. So we're just wanting to make sure everything's okay. And to let you know as well. Okay. All right. And then scaling your success, optimizing the care delivery. And this is actually what Kate and I have been referring to each step of the way. Our team, the care team, will provide pre-appointment guidance, as well as the cardiologist when they are able to connect with the PCPs, or the care teams connect each other, connect the cardiologist and the PCP. This way, we've already done the research, we've done the data review, and we are then reaching out to the PCP with that guidance ahead of the appointment. Most times our care teams talk with the provider's care teams, and we know when Miss Maria's next appointment is coming up, and they'll say, hey, do you have anything for us? Can you give us a call back after we've met with her as well? And then we're able to have that touch point before she's in, and after she is left the provider's office as well. So it's not a one and done type of situation. We really try to ensure every approach is available and beneficial for the PCP and their care team's time, really. The video consults, that's another Kate mentioned earlier. This can reduce time to gap closure by providing the faster remote access. So you don't have to call the patient back into the office. That, we know all too well what comes with a patient getting to clinics at times, the transportation issues, the burden of rescheduling appointments, or finding that approach that meets the patient where they are. This is one of them. A video consult is very easy for the specialist, and even the peer-to-peer consultation with the specialist and provider, or we can meet with that, as Kate was saying, we can meet with the patient as well. We typically would look to the PCP to enable that and give them that recommendation and say, this is a great resource for you. Let's use it, and let's see what we can come up with together, and really partner with the AristaMD cardiologist. And the PCP is still really the quarterback of this relationship, and making sure that the patient feels heard and that everyone is on the same page. Especially with eConsults, that after visit summary, as we all know, visiting a clinic, we'll get an after visit summary. Same thing with an eConsult. It looks very much the same. It can be uploaded to the patient's chart. They can find it themselves now most times within apps and such. They'll be able to just review exactly what the cardiologist said. If the PCP calls the patient and says, hey, we want to get you started on this medication and here's why, let's pull it up together and review what the specialist said, and we can determine how you feel, and we can make a plan, care plan after that. And then the last would just be the in-person appointments. Those are reserved for clinically necessary cases and ongoing patient objections. So those patients that just are very, very sick and also just for various reasons do not want to take the medication. And those are when we would see those at times. Kate, is there anything you want to add to this?
Yeah, I think there's a couple of things. I would say that, 80% or more we address with pre-appointment guidance. And one of the things that we do look into in pre-appointment guidance, and something that frequently falls through the cracks, is exclusion renewals. They have to be documented in the calendar year of the measure. Even if they have a prior year exclusion, you still want to make sure that that documentation is done appropriately in the current metric year. And there are varying rules depending on the gap that you're looking into about what qualifies. Is it a prior year exclusion qualifies for the current year? Sometimes you need to redocument that the patient still qualifies. Or in some cases, for example, with cancer treatment, they were in exclusion in the prior year, but now this year they are no longer in exclusion. So that's part of what we would do in that pre-appointment guidance, is make sure that the PCP is kind of aware of, here's what's changed with that patient. And then with the video consults, again, we will do the peer-to-peer, and that's great if there is a huge number of patients that need to be managed. Sometimes that's with the CMO of a practice group. Sometimes that is a really effective way of going through all of the patients. Sometimes that's directly with a PCP. Again, for the in-person care, I think there's two important things to take away from that. Our team will facilitate communication between a PCP and a cardiologist. So if we see the prescriber of the statin is actually the specialist, but the statin hasn't been filled, we will reach out to that specialist and make sure that the PCP is informed of the outcome, and that information goes back to their care team. So we are trying to provide that coordinated care because we can often have visibility to that in the claims data, and we want to make sure if they've been a prior prescriber but there's not a current fill, that the PCP is aware of that, and that there's that appropriate communication and documentation either on behalf by the PCP or by that specialist to make sure that patient is either getting the statin they need or getting the blood pressure readings they need and the medications they need, or those exclusions are documented by one or both providers.
Yeah, that's a great call out. I saw Tiffany added a question in the poll about the biggest challenge when it comes to closing care gaps, and this ties in as well. Most said missed or delayed screenings, and that's what we do. We create flags for your care teams. We've utilized the EHR. We can tell you, hey, did you know it has this feature? You can add these flags into the system. Hey, did you know once the provider closes out their notification for this gap that it's not going to pop back up? You have to go in and regenerate it if they accidentally hit the X button or whatever. So we have a lot of expertise in many of these situations because we know, and our cardiologists will also say that we know that it's the providers most times just are unaware that it's happened. And therefore we would love to be able to step in and say, hey, we have an open gap. We want to talk to you about it, or either just let you know, did you know that this is open?
And I think with screenings, it becomes particularly complicated. If we look at dementia or women's health screenings, screenings for behavioral health, things of that nature, often a patient is seeing not just their PCP, but also specialist. And if that screening was done in a prior year by a specialist, but it's not done in the current year, then it is on the PCP to make sure that happens. And we want to be able to alert you in that pre-appointment guidance. Hey, this patient is due for this screening. And while yes, they received this screening at a neurologist last year, the patient may no longer be seeing that neurologist. You probably need to perform that screening this year.
Absolutely. Yeah, that's great. Okay, let's see what's next. I was enjoying that conversation so much.
I know. Okay. So over
we get so passionate about this. So
yeah. So we're very enthusiastic. You want to take the slide?
You go ahead. Go ahead,
Okay.
Kate.
So this gives you kind of our longitudinal service offering, which we consider this part of it, because it uses a little bit of all the services that we have to offer in organizations. So that performance oversight, where we're looking at your population health data, we're telling you who has the care gaps. We review the charts to make sure that the care setting and the evidence-based care plan that closes the gap is appropriately identified, documented, and that the PCP has all the information they need to get that evidence-based care, including an appropriate screening, which is really important. Care delivery. So one of the things that Xanthe and her team are experts at managing is what is the best approach for a patient? And often what happens is we give the pre-appointment guidance. The patient may have some objections, or they may have started taking a medication or have concerns about the results of a screening. That's where an eConsult might come in, or a telehealth visit. So they can provide recommendations to the care team. That's the most common way, is the follow-up, because the PCPs are busy. But they can we want to act in alignment with the PCP, so that if the PCP has had the conversation, the care gap still remains open, and there are patient objections or patient symptoms or concerns, that we're routing that patient to the next best convenient and appropriate setting. And that's where care support comes in. So in that situation, if it is a telehealth visit, we can help navigate. If there's communication with a specialist or an in-person specialist, whether it's their current or a referral to one, we can help make sure that that information comes back to the PCP, that the care gap was closed, and the nature of that closure. That's why step 5 is so important from our perspective, because the PCP really should be at the center of care. And the monitoring continues. Xanthe has brought this up, but even though we see SUPD gaps open and close and then reopen, her team is always making sure that they close again wherever possible. And that often is because there has been an issue with the patient's compliance. In other cases, it can be an issue with social determinants of health. They lack transportation, or they can't afford the copay, or there are some other mitigating circumstances that are preventing them from being compliant with the PCP's recommendations. So we want to support that as well. Here again, this is where that non-compliant patient, we're going to come in with a strategy, not with a reminder. We don't want the PCP to be left on their own. We want to say, hey, here's what we see in the data. Here's what the patient did. Here's what they haven't done. Here's the next steps. Here's some options that you have in terms of redirecting the patient to give them the confidence that they're on the appropriate treatment plan, because there are situations where patients says, well, I'm not comfortable with that. I want to go out and see a specialist. That's great. We can help facilitate that. And again, make sure that that documentation is done appropriately, so the care gap closes on the PCP, who is carrying the financial burden for that patient. I think that's particularly important. Again, so that's where the care delivery might get routed in. We're going to confirm that the care gap is closed, stays closed. And then, we're obviously reporting back ongoing, but ideally, you're going to get that full year summary as well as, did this program, and yes, it will, impact care gap closure? What was my return on investment? And did it improve my patient outcomes? And that's what we'd like to demonstrate at the end of the year. But obviously, we get leading indicators of that as we see the care gaps close early in the year, and we see that impact ongoing. Any other comments to this one, Zan?
No, I think you captured really well. That's full scope of our picture.
All right.
So we just wanted to mention a couple of key takeaways. Some of those are very achievable goals. Those of my team are the outreach goals. We will target 600 gaps per week with a tiered system approach within our 90-day roadmap. So I just wanted to explain that, give you that preface of what does a 90-day roadmap look like. We identify our biggest care gaps right out of the gate. We will run reports and ensure that we are seeing each and every data point that brings that picture together for us to deliver to the PCP. And we listen to the PCPs and their care teams. If they're wondering about another data piece or something, if you can check on this for me, have you seen this? Those are things that we like to include in our conversations, the next follow-up. So then we will pull that data source, that data piece into our conversations and ensure it gives that PCP the full picture that they're looking for. But within established specialist access protocols, and we'll also ensure that PCPs can quickly consult the specialist on those complex cases. So as we make our way through and the PCPs begin seeing their patients in clinic, to add those statins or take those BPs or have any of the other measures that adherence, those are most times we see a lot of issues with compliance for the full measurement year. So any of those will ensure that the PCPs can consult the specialist quickly for those complex cases. If they need to speak to a specialist before Miss Maria comes back, and let's say she was more hesitant the first year than the last, but then she was able to hear from our PCP who spoke to the cardiologist, we ensure that we work around the PCPs. We also do implement, as Kate was saying, the performance tracking. We monitor those gaps really closely and the rates by the provider and the measure type, as well as where that provider is providing access. So if there are multiple clinics, or if a provider does some shadowing at a local hospital and what have you, sometimes those patient populations are separate, and we ensure to keep those separated. And those touch points are to the utmost, like HIPAA guidelines. We want to make sure that we're keeping those appropriate. But if we are able to connect with the PCP and they would like a full scope, hey, can you look into all of my patients for me? We're happy to do that as well, and we have the access to do so.
And let me just, before we leave, were you wrapped up with that? I'm sorry.
No, yeah, go ahead.
Yeah, so before we kick off a program, we do try to set goals. Now, they are different for each measure. So we've just given a couple of examples here. The proportion of days covered. If we want to get to 80%, we want to target 90%. Achievable gap closure rates, depending on the size of your population, the number of gaps you are trying to achieve, if you're already at a 4-star rating, right, you may not have a huge portion of your population, but we can typically move you from 4 to 4.5 stars. So, what exactly goals are you as an organization trying to retrieve? And again, what's the ROI that you're looking for? There's an ROI associated with closing the gaps and achieving the star rating, but there are additional return on investment that we can achieve. So where do we want to focus our measurement of the program? Is it ED avoidance? Is it inpatient avoidance? Is it appropriate drug selection? Is it care escalation? These are all examples of different metrics. Some of it is it keeping the patient within the purview of the PCP? We know that if you refer out to a rheumatologist or a cardiologist or a nephrologist, sometimes that patient doesn't come back. The nephrologist ends up being the primary point of care. We want to help facilitate and make sure that PCP that holds the patient's value-based care under their responsibility always has that visibility and the ability to influence the care for the patient and make sure that gaps stay closed. And then, is there an annual quality bonus that you're trying to receive? Let's try to target that. Let's hone in on that and see where, and track that metric throughout the year so that, we're not just waiting to the fourth quarter to try to figure out how to close it. Because I don't want to say it's too late by then. It's not always too late, but you're going to be much more successful the sooner you start, because by the time you get to the fourth quarter, people are focused on those holiday timeframes where there are fewer appointment days, there are more vacations, patients and providers going on vacation, taking time away with their families. So we want to make sure that we get that process in place and those achievable goals defined at the beginning, with the context of where are we in the year and what can we actually close for this year.
Yeah, that's a great point. I was thinking as you were saying that, Kate, about how if we are with an organization, let's say we come in mid-year, mid-measurement year with them, and we're given a big data dump or what have you, we're able to really start with a high 600 gaps per week is high for most cases. But if it is new to the measurement year, then those at times could be lower because we all know claims data takes a little bit. However, if we have that continuity with those organizations, we target those providers and patients that were left open at the end of the year that maybe just didn't quite make the finish line. Then we're able to proactively reach out to them before the gap even opens that year. So we are also providing the proactive approach as well as reactive when that gap opens. But that's been one of my favorites in the past with seeing how we can give an organization a target list and say, hey, this is how many you ended your year with, and we're now wanting to ensure that these don't reopen, and we'll have a full session with them and get them all set up with their patient flags and these and what have you. They'll call those patients in earliest for the appointments for the year, for those checkups and what have you, and get those closed before we ever even see them open. So that's been really fulfilling.
And since I know we have a few of our clients on the call, one approach we would take, particularly at the beginning of a calendar year or right as we're kicking off on a program, is an eConsult first approach, so that we can get that information in the hands of our PCPs who are already familiar with the eConsult process and say, hey, here's an eConsult. You have this open gap for this patient. Their next appointment is, which the care team often has visibility in working with the PCP's care team of saying, the eConsult's delivered, the patient appointment is on Thursday. Here's what you need to achieve and document in order to get this gap closed during the appointment. And I don't want to say they hand it to them in a silver platter, but they do everything they can to make it seem like it came on a silver platter.
Yeah, definitely.
So we're getting close to the end, and I think this is like kind of a summary of what we just talked about. So, this is how, and it isn't as formulaic as this, but this is kind of our loose guideline or swim lane for how we move forward when we launch a program. The foundation phase of understanding the data, understanding out where we are in the measurement year, who we can impact, who's at the greatest risk of diminished outcomes or, ED visits, for example, with those complex conditions, or if it's earlier in the year, who ended the year with a gap, and let's close it before it opens. So, that's a particularly valuable point. We try to deploy the most cost-effective and efficient process first, which is that pre-appointment guidance, because we know it has an impact. If we can see in the patient's chart that they've started a statin, stopped the statin, or, in our conversations with the care team, we know that the patient has complained of, symptoms or concerns, or their blood pressure readings in the prior year were all over the map and there's no consistency. If we can provide that pre-appointment guidance or an eConsult in advance of the appointment, especially eConsult for those more advanced or complex cases where they have multiple chronic conditions or multiple open gaps, pre-appointment guidance might not be enough. A detailed e-consult may really be necessary. So we're going to do that in weeks 3 and 4, and ideally time those with the next patient appointment. So the appointments that are scheduled, those are coming first. And then we're going to get those other patients on the schedule as soon as possible. During month 1, we're really going to work on that exclusion documentation because it isn't the first priority, because you can't impact the outcomes by closing the gap for those patients, but you can impact your revenue. So while documentation is always important, your biggest urgency is on patient care, which is why it's our first focus. And then we're going to capture that documentation ideally without any input from the PCP except at the time of patient care. So what documentation do I have to provide in here to make that happen? And then when we get into months 2 and 3 and beyond, I would say Xanthe's team provides a more flexible approach. We start to see patterns within any organization, and we're going to focus on those patterns that have the greatest impact. You can see them here, and again, we'll be sharing the slides and a copy of this video afterwards. Those 2 months were primarily focused on how do we modify the program to meet the specific goals of your organization and the specific situation of your patient population. And welcome back, Tiffany. Do we have any questions? I know we're hitting the end of the call.
Thank you so much, Kate and Xanthe, for that incredibly valuable presentation. You guys really helped break down what it takes to close care gaps in a very meaningful and scalable way. We're now going to open it up for Q&A, so please go ahead and drop any questions into the chat, and we'll do our best to get through as many as possible. Also, if you haven't yet, please take a moment to respond to the poll that you will see on your screen. We'd love to hear about the biggest challenges that you're currently facing when it comes to care gap closure. And like Kate mentioned earlier, we will be sending a follow-up email with the full webinar recording, so you'll have it available to rewatch it or share with colleagues. Let's jump into our first question, which is, how do you operationalize care gap closure workflows without adding significant burden to PCPs or support staff?
Great question. Operationalize the care gap closures by implementing those EHR workflows, finding specifics to the tools that they already have, especially if we're able to speak with some of the administrative staff. We can get passed off and walk them through those approaches and ensure that those are going to be kept up with even by the admin level. So there are very small things like that that can be easily utilized that will reduce the burden. The patient will have that flag as soon as the provider sees them in clinic, and we've seen that be successful.
Thank you so much, Xanthe. The next question that we got was, what are the most common errors or blind spots that you see in gap closure efforts, and how can we avoid them?
Blind spots. Most errors or blind spots that we see typically happen with the exclusions. So those, like I believe Kate mentioned this throughout the presentation, but those gaps those exclusion codes need to be followed through the next year if that patient still meets that criteria. It's very important that if they previously had a myalgia, but this year maybe do not have a myalgia documentation or just no need for that, then we want to ensure that it's not a false exclusion. But if the patient is, let's say, very sick, ESRD, has been in and out of the hospital and what have you, most times in the data we can track and see that this patient is very sick, and we want to ensure that provider has brought that exclusion code forward in the next claims data when they see them next.
Thank you so much, Xanthe. And to not take up too much time, since I know that we are going towards the end of the webinar, I will be taking one more question, which is, how do I know which patients are more likely to benefit from pre-appointment specialist inputs, like in Maria's case?
I'll take this one.
Yeah.
So I'm going to speak very complimentary of Xanthe's team, and this is something you don't have to do. What they're going to do is actually look through the claims history of that patient, and they're going to come to you with recommendations so that you don't have to go back through all of that data and try to figure out how to prioritize. Again, each patient population, we do see some patterns. Some of those are driven by geographics, by the age of the population, by the economic mix of the population. And when we see those patterns, again, her team's course correcting and saying, okay, now that I'm starting to see these patterns, I'm looking for these specific types of things in the data. Not that they're going to miss anything, but it helps us kind of float things to the top. We do have an analytics team that supports us so that, it's pulling up and summarizing that information. And that's kind of one of the services we offer, because we recognize that even though there's a lot of population health tools out there, cutting through a tremendous amount of information is difficult. And so they're going to provide that guidance when they come in, which is why we're often, depending on the size of the practice, we are often starting with your person responsible with quality, or responsible for Medicare Advantage programs, or, there's 1,000 titles that align with that. But, we're going to work specifically with that person and then take a top-down approach, again, so that we're aligning with your practices, policies, workflows, and coordinating based on that. So, one of the goals that we have is to not make you dig through the data, to let our team, who has a tremendous amount of experience working with this information, find those gaps, float them to the top, prioritize them for you, and get them closed as soon as possible.
Mm-hmm.
Thank you so much, Kate. That's all the time that we have for today's session. Thank you all so much for joining us and for the thoughtful questions and engagement throughout. We'll be sending out a follow-up email shortly with the webinar recording, so please keep an eye in your inbox for that. And of course, a huge thank you to our presenters, Kate and Xanthe, for sharing their expertise and practical insights on care gap closure. I hope everyone has a great rest of your day. Thank you.